Welcome to the What Paramedics Want podcast series of Inside EMS, sponsored by Pulsera. Whether replacing radio reports, alerting specialty teams, or managing mass casualty incidents, Pulsera simplifies communication, one tool every day, regardless of the event. Well, welcome back once again to Inside EMS. I am your host, Chris Cebollero, and here he is, the man of the hour, too sweet to be sour.
The ladies
know I'm the man with the power. I'm gonna have to put that in. I'm gonna have to put that in the intro, just so everybody can hear what that exactly sounds like. Kelly Grayson, what's going on up there in the?
I'm good, man. We're enjoying the snow and the cold. Well, I enjoy the snow and the cold weather. Nancy absolutely hates it, but I think I'm gonna drag her out to Titus Mountain today, and we're gonna go tubing. We're gonna take some inner tubes down the sledding hill.
Some good sledding is going to be going on with a foot of snow up there, huh?
Oh yeah. It's well, they make their own snow as well, but when the weather doesn't cooperate. But Titus Mountain's got a nice little public ski resort there, and but I've never learned to snow ski. I can water ski. I don't know how much harder it is than water skiing, but and that's equipment intensive. I don't plan on buying a bunch of skis and stuff, but I can get a little drunk and slide down an inner tube.
You can rent that stuff too,
Yeah, probably.
Snowboarding would probably, if you haven't gotten on skis before, snowboarding would probably be better.
Yeah. Okay. Well, I'd be like hydrosliding, which I've done before, and wakeboarding.
Yeah, exactly. Yeah, except you're on your feet, not your knees. But
no, I've stood up on hydroslides many a time.
Oh, have you really?
Yeah.
Jesus, you're a better man than me, Gunga.
Well, that was many pounds ago, but I'm getting down to that point where I can do it again.
Yeah, I actually saw one of your pictures, and it was one of the ones. It's the one in the jacket and the blue shirt that you send out usually when you speak. I mean, it's a considerable difference.
I got to get some new headshots. Yeah.
So, Kelly, as we talk about headshots, the reason we send them out is because we do our things at the conferences, and we kind of bring education to the masses. And one of the ones that I saw that you had was really about the AAS system, RAAS. What the heck am I thinking?
Lexic.
The renin angiotensin aldosterone system. But you always come up with those interesting names too, the anatomy of a pew.
Yeah.
As you break that down. But tell people we're going to talk about this one that you just did recently. And we're going to talk about the renin angiotensin aldosterone system. I think it's going to be a hard show, but we're going to do our best to try to make it as simple as we can.
It's been a while since we've had a clinical issue topic.
But how do you come up with the names of these things?
Man, these are my elevator pitches.
First, share the name of the lecture.
It's called the renin angiotensin aldosterone system, not just a planetary belt in Star Wars. And I come up with, first of all, I seek to find new ways to package stuff and present information, put a new spin on things. And when you write titles like that, it's basically the elevator pitch. You want to catch somebody's attention and interest in 30 seconds or less when they're scanning a conference program. So if you make it attractive enough in the conference program, that's how you get people in to choose your lecture to attend. So this is one of them. This lecture, there are two versions of it. There is an ALS lecture, which is a really, really deep dive into the RAAS and the alternative RAAS. And the other one is part of my explainer series, where I take complex topics and break them down into BLS terms. And that's what this one is.
Very awesome. And yeah, I mean, you look at those titles and you look at those descriptions, and then you see that Kelly Grayson is teaching it. You don't want to go anywhere near the room. So, but let me ask you this first. I mean, before we get into this, what is the RAAS system? What is that for? What's going on there?
The renin angiotensin aldosterone system, in a short spiel, it is the neurohumoral response to shock. It is how your endocrine and central nervous system respond to low perfusion states. We are all taught as EMTs, what shock looks like, But what we're often not taught, and sadly so, still not taught, is what mechanisms drive that. You know, I ask my students, or I ask EMTs that have been taught elsewhere, okay, what does shock look like? And they go, it's cold, clammy skin. They're tachycardic. They're breathing a little fast. They got weak or absent peripheral pulses. And I say, okay, yeah. So what mechanism drives that? Crickets. They're like, okay, so, you know, and then I explained to them vasoconstriction and what that does. And I said, okay, well, what if a patient is in shock because of vasodilation? There go all your signs. You need to understand shock at a deeper level and how that comes about, what physiologic mechanisms drive that. So the renin-angiotensin-aldosterone system is a neurohumoral response to shock. When your kidneys, the juxtaglomerular apparatus, it's a fancy word for a baroreceptor set in your kidneys, in the glomerulus, sense low pressure states, they release renin, which renin from your kidneys travels to your liver and converts angiotensinogen into angiotensin 1.
Right.
Angiotensin 1 is the snuggle fabric softener bear of hormones. It
Yeah.
ranks on the threat scale slightly above baby ducks and below Chris Cebollero. But
Well, let's polish that a little bit
okay,
before. So, for those of you listening at home, if you know if your heart isn't pumping enough blood, you're in shock. It could be because of vasodilation or vasoconstriction. The blood necessary doesn't get to the kidneys,
yeah,
which is the most. I mean, it when you talk about the liver, when you talk about the kidneys, it needs the most blood as it now starts to do what it needs to do throughout the body. So all of a sudden, the kidneys aren't getting the supply that it needs, and it releases this chemical, angiotensin or renin, as it makes its way through the body. Now what happens is it starts to convert. So take it from there.
angiotensin 1 is fairly benign, but when it travels to the lungs, an angiotensin converting enzyme converts it into angiotensin 2, which is a hugely potent vasoconstrictor. And it and a couple other things are what drives that vasoconstriction in shock and causes those weak and absent peripheral pulses and that cool, clammy skin and that sort of thing. Angiotensin 2, pretty potent stuff. In fact, you know, blood pressure medicine, ACE inhibitor blood pressure medicine, lowers blood pressure by preventing that conversion from angiotensin 1 to angiotensin 2. Angiotensin 2, in turn, signals your posterior pituitary gland to secrete antidiuretic hormone, and which causes you to retain fluid and not urinate so much. And meanwhile, it also signals your kidneys. It activates your sympathetic nervous system, speeds everything up. Epinephrine and norepinephrine are dumped into the bloodstream. And meanwhile, your kidneys also produce aldosterone, which is another hormone that promotes fluid retention. So the upshot of it is your kidneys understand, oh, we're losing fluid here. Let's not lose any more, and let's constrict the pipes down so we can get adequate pressure to perfuse us. The problem with that is
Hang on, stop
that's
at the
great
problem.
in, yeah,
Stop at the problem.
yeah,
Let me go ahead and brush it off as what
yeah.
exactly what you just said. So save the problem.
Okay.
All right. So as Kelly says, and there are some people that, they have to picture it. So,
Yeah.
close your eyes and kind of picture it with us. So the kidneys now say, we're not getting enough blood. Here's this renin that we're going to send out because we've got to fix this problem. What the body doesn't know is that Chris Cebollero and Kelly Grayson and you are out there trying to fix it. So it's trying to fix itself, right?
Yeah.
And that's kind of those compensatory mechanisms that we have to deal with as paramedics, and sometimes we don't consider. So the kidneys send out renin, it gets to the lungs, it converts with the angiotensin converting enzyme. So as Kelly mentioned, this is the word ACE. So when you hear people that are on ACE inhibitors, it's
Right.
stopping this practice from happening, right? It's
All those
stopping
drugs that end with prill.
right. So now what happens is, think about this. You got your eyes closed, you're picturing it. The lungs convert this to angiotensin 1, angiotensin 2, or angiotensin 1, angiotensin 2 with the angiotensin converting enzyme ACE. Now it starts to become a vasoconstrictor.
Yeah.
Now, I want you to picture this. The heart is having an ejection fraction problem, meaning that it's not pushing out all the blood that it needs to because you have you have a cardiac issue.
Yeah.
Now what happens is that the heart has constricted, the kidneys are getting less and less blood than they were a few minutes ago, right?
Yeah.
So that's why these ACE inhibitors come into popularity, because we can't have that. It's a shock thing, but it also could be a cardiac thing. All right. So now pick up the problem.
And it's the problem is in vasodilatory shocks, like distributive shock, anaphylaxis, sepsis mainly. The problem with that is that this mechanism damages the heart, or it imagine a weak failing heart like a weak engine. If your engine barely gets you from point A to point B, it's not real good for it to drive with the parking brake on and no air in the tires. And basically that's what angiotensin 2 does, is it causes that peripheral vasoconstriction, but that it increases the pressure against which the heart must pump to eject blood. For a failing heart or a damaged heart, that's pretty bad stuff. And this fluid retention, this elevated fluid retention in the kidneys can also cause acute kidney injury. So one of the things you see in these patients with vasodilatory shocks is they often have some degree of cardiac insufficiency and some degree of acute kidney injury. So there is a counterbalance, a counter mechanism to that called the alternative renin angiotensin aldosterone system. And I won't go into huge detail on that, but think of it as just a countermeasure to keep it from going haywire, keep it from vasoconstricting too much. It starts to break down angiotensin 2 and some other mechanisms kick into place, but it actually prevents your blood pressure from getting any higher or your vessels from constricting anymore. And that actually, even though it doesn't help the blood pressure much, it is thought to be cardioprotective and renal protective in some way. And we're still learning about the effects of the alternative RAAS. But I think that EMTs, so much of EMS education is focused on monkey see, monkey do. Don't really, if A, then do B. If X, then do Y. And you don't understand why. But understanding why gives you a leg up in treating the problem. We had a septic shock patient yesterday. Nursing home had a non-rebreather on her at 6 liters a minute. Okay, it's better than nothing. We go in, and my partner, she also had Parkinson's. My partner goes in, checks a blood pressure, and gets a manual blood pressure of 128/60. He was hearing Parkinsonian tremors instead of garrote cough sounds. Slapped the cardiac monitor on her, her blood pressure is 52/38.
Right.
Yet she has blood pressure, she has warm pink skin, she has capillary refill 2 seconds, she has peripheral pulses. They're kind of thready, but still there, and a heart rate of 80. Care to guess what kind of blood pressure medicine she was on? She was on ACE inhibitors and metoprolol. So he asked, was like, shouldn't her heart rate be faster than that if her blood pressure is that low? So not with these medications.
Right.
And if you don't understand how your body compensates for shock, you don't understand what those medications do. And we got her to the hospital, and she was in bad shape. But
Yeah, it sounds like you did a good job. But let's go ahead and take a quick break, Kelly. And then when we come back on the other side of the break, let's talk about how we treat this. Let's talk about how we fix this in the field. But let's go ahead and take our break. We'll catch you on the other side.
And now a word from our sponsor.
Pulsera scales to meet your dynamic communication needs. From routine patient alerts to managing large-scale emergencies, every responder and clinician connects seamlessly. Familiar yet powerful, Pulsera streamlines your response. From routine transfers to regional disasters, it's one tool every day, regardless of the event. Discover more at pulsera.com. We are back. We are bad. We are continuing our discussion.
We're nationwide.
That's right. About the renin-angiotensin aldosterone system. And, Kelly, I think we laid it out. And it's a tough topic to kind of talk about without visuals. And we tried to be very, very basic as we could with this. But now let's talk about this. I mean, you mentioned before we went to the break about the patient that you saw and the presentation that they had. I mean, all the things that we would notice in shock weren't there.
Right.
And because this patient had Parkinson's, there was a misread of the blood pressure, which could have really signaled that I don't need to do much here for this patient.
Yes.
When in fact blood pressure was low, and this was a patient who was going to
Yeah.
crash pretty darn quickly. But as EMS, as paramedics and EMTs rather, when we identify this, what are we supposed to do?
Well, that's the thorny issue. The traditional response has always been to load the patient with fluids. Load the patient with fluids. You know, now we know from Ken Maddox's research that that is not beneficial. In fact, it's harmful to give large volume fluid boluses to patients in hemorrhagic shock.
Why is that? Why is
Because
that?
it counteracts, in a sense, hypotension in hemorrhagic shock is a compensatory mechanism. It allows the blood pressure to lower a little bit so that platelet plugs can form. And when you jack the pressure up artificially with large volumes of IV fluids, it jackhammers those clots loose. It doesn't carry oxygen, and it dilutes all the clotting factors. And there's a mountain of research showing that it makes patients worse. But the still large volume fluid boluses have been held to be the standard for sepsis and distributive shocks. But that's a matter of controversy as well. You know, the Surviving Sepsis campaign and most sepsis guidelines state that you give 30 milliliter per kilogram fluid boluses for patients in septic shock. Yet we know that at least half of our patients that are hypotensive and shocky cannot physiologically respond to fluid boluses. So those people need vasopressors. Now, it's outside the scope of this talk, but there are simple clinical ways. Even an EMT can tell looking at monitor waveforms, pulse ox waveforms, and CO2 waveforms.
Yeah, let's talk about
Whether a patient can, yeah, we'll talk about that another time. But there's ways to differentiate whether the patient needs vasopressors or fluids. In this case, she needed vasopressors. She needed vasopressors,
But
and
how'd you figure
I
that? I
couldn't
mean,
get a line in her before we got her to the hospital.
yeah, but how'd you figure that out? I mean, so basically, I think when you got the second set of vital signs or the
Yeah,
second blood pressure, you realized, oh my gosh, she's in
yeah,
shock, and we've got to be able to address that. You weren't able to get a line, you said, but how'd you
yeah.
treat her?
Keep her warm and rapid diesel infusion. If I were 15 minutes from a hospital instead of 4.5, I'd have kept stuck it. I'd have kept sticking, and I'd have gotten a line one way or the other. And we have alternative means of vascular access. In this case, I didn't go that far. Number two, we found out our patient was a DNR patient. So,
Well, DNR doesn't mean do not treat. It just means don't resuscitate.
but it was simply a time factor. I didn't have enough time. Had I had enough time, I would have, if fluid loading was indicated, I'd have given her the 30 milliliters per kilogram of fluid. Otherwise, I would have given her vasopressors. I just didn't have time to do either one.
So let's talk
The
about
thing
that.
is what stuck us is my partner did what good partners do. He didn't trust the cardiac monitor to get a reliable blood pressure. So he took a manual in first. That's what he was taught, and that's the right way to approach things. He was taught that NIBP measurements are unreliable. They are if you're looking at systolic blood pressure. It wasn't until we got in the back of the ambulance, we loaded the patient, got in the back of the ambulance, that I took a second blood pressure, and oh my goodness, and everyone after that was sucked. And the mean arterial pressures went in the like 40s, 30s.
So
Not good.
you would have gave fluid in this case. Would fluid have been
No, I
warranted?
would have given vasopressors to her.
Okay.
She had indicators that fluid loading was not going to be efficient.
What do you carry that is a vasopressor on your
We
end?
carry norepinephrine,
Okay.
Levofed.
And
And back in the day, Levofed, we used to, what we call it, Chris?
it was the magic tool.
Yeah, we also called it leave them dead,
Yeah.
because all of that potent vasoconstriction that Levofed causes was thought to be harmful. And, it is harmful in the same way that unregulated vasoconstriction is worse for those patients with heart failure and those patients with kidney problems. But, it's one of these damned if you do, damned if you don't. You got to get your patient to the hospital alive.
Yeah.
So it's one
When
of
they
those
got to the
trade-offs.
hospital, did you know how they treated her?
Yeah, I was in there apologizing the entire way. I couldn't get a line. I'm sorry. I didn't realize her blood pressure was in the toilet until I was 2 minutes away. Sorry. And they were fine. They were working to stabilize her, getting vascular access, labbing her up and everything. Could have been better on our part, but it really didn't alter patient care that much. Not
All
with
right,
that
so let's
short
go
of
ahead and run down the symptoms then. So in this case, because one of the things that you thought is you went down this decision tree to
Yeah.
figure out that there was a fluid challenge, to figure out, I'm sorry, that there was a blood pressure challenge. She did have good, warm pink skin, good capillary refill. So as you go down this decision tree of getting to a point of saying, this patient's in shock and we need to give some vasopressors, what were you looking for? What did you see that said, I can't give this person fluid, I need to give them medication?
her pleth waveform, was uniform. If your pleth waveform oscillates between high and low amplitude, that's a sign that they are fluid deficient. Her pleth waveform was fine all the way through.
Break that down though for the people who are
The
listening that may not
pleth,
understand
the
that.
plethysmography is the visual readout, the waveform of a pulse oximeter on your cardiac monitor, or if you have one of the newer fingertip pulse oximeters, it puts a wave there. That wave should be the same height, the same width, the same rate all the way through. It should be very uniform. But if it oscillates high, low, high, low, high, low, that actually is cycling with the patient's breathing. When they breathe in, it drops. That's a sign that the patient's cardiac output can't keep up with negative intrathoracic pressure. So when you see that, that tells you that patient is fluid deficient. If they're not doing that, if their pleth waveform is fine, they're probably not fluid deficient. The other thing that we could do, but I didn't have a chance to do, is use a CO2 nasal capnograph line, and you put the nasal capnograph line on them and lay them on their back and elevate their feet, do a passive leg raise. And if their CO2 level comes up, that is a sign that they're volume deficient and fluids might be indicated. In this case,
Yeah, that's a
didn't get
good,
chance to do that.
but here's what I want to point out here. A lot of times we put these diagnostic pieces of equipment on our patients and we're not utilizing it to the
No,
best
we're
of
not
its
ringing the
ability,
potential. Yeah.
right? We look to see if anybody's if everyone's between 35 and 45 millimeters of mercury, and we know that that's kind of normal. But the
Yeah.
capnograph and the pulse ox was something that, not necessarily pulse ox, but the capnograph was something that is a powerful, powerful tool that
Mhm.
if you really learn what's happening on the capnograph, as Kelly mentions, the pleth waves and, lifting the feet
Yeah.
and, increasing the CO2,
Yeah.
you could really get to the definitive end to what's going on with this patient.
Yeah.
And we don't use those tools to the best of our ability. It's just like when you listen to
Yeah.
heart tones. If you get good at listening to heart tones, and I think we've talked about it on this show a lot of times, that listen to everybody, listen to everybody's lungs, listen to everybody's heart, even if they just have knee pain, because if you can learn what normal is,
Really is.
you
You can
will
recognize
hear,
that.
you will hear that when there's something that's
Yeah.
not right. And then you can go to the doc when you get to the hospital and say,
Yeah.
Doc, can you listen to their heart? There's an extra beat in there. I don't know what that is. You've just
Boom,
taught
boom.
yourself what an S3 gallop is.
Yeah.
Right. But,
Yeah. And thank
Kelly,
God for amplified scopes, because I couldn't do that before. Now I can.
really, you couldn't.
Well, I have hearing loss, high frequency. Yeah, it really doesn't affect, but I have a hard time tuning other things out. But
Yeah, I have
my echo,
the echo stethoscope.
yeah,
So
I have with my echo, I can appreciate
you
those
can
things.
hear.
So
And then we record that. But, Kelly, I think we did the best job that we could on a
yeah.
tough topic, but it
Yeah.
sounds like we have a clinical issue here.
Yeah, we do. And if you'd love to see this, I'm doing this lecture in Nebraska and several other places this year, but I'll be in Nebraska in a couple months doing it. And I think that there is no ceiling on knowledge. There is a scope of practice, but there is no scope of knowledge. And the more you learn, even as an EMT, about how the body works, the more informed your clinical decision making is. And believe it or not, it can make a difference in what you do, even as an EMT. But hey, that's what I think. We'd like to hear what you think. What were you taught about the renin, angiotensin, aldosterone system in school? In AMT school, probably not. In paramedic school, how deeply did they cover it? We'd like to hear your thoughts at the show at ems1.com. And for myself and co-host Chris Cebollero, thanks for tuning in to Inside EMS. Going to catch you next week.